Okay, I'm gonna get started. So I'm Brian Buchanan. I'm one of the ICU doctors at the University of Alberta. My main interest is in ultrasound and critical care in research and administration and education. So this rounds will be the LV and critical illness of headaches and heartaches. Let's talk about the cognitive visual skill set to understand and perform focused echo to evaluate LV function. I try to make this as broad as I can. I mean, there's some basics, there's some more advanced stuff. It's a pretty big mix. We'll troubleshoot LV into qualitative domains, go through some actual image interpretation, talk about global versus heterogenous wall motion abnormalities, and integrate our findings into clinical assessment. Feel free to stop me anytime if you have a question at all. If you want to raise your hand, you can do that. Hopefully I'll notice you. If I don't notice you, just yell at me because you know, when you're talking, it's sometimes a bit hard to watch everything. So why do we care about LV function? Obviously, I mean, you guys are all here. I think it's fairly obvious. You know, echo is a great way to assess LV function in ways historically that were far more challenging. So like with a clinical exam, for example, and, you know, pulmonary artery catheters, which are far more uncommon now. And there are also, you know, a number of non-invasive things out there, like NICOM, for example. There's examples of mats that can allow you to calculate cardiac output non-invasively, but of course, these things are expensive and access is fairly variable. And really, you know, patients that we see in our ICU, a mixed kind of medical surgical ICU with you know, just a mishmash different patients, they have complex illnesses, and it's often hard to separate what's really the actual problem. And if you detect LV dysfunction early, hopefully you can change the trajectory, you can intervene early, you can get early referral or early triage to more advanced studies. And the fact is that, you know, from my experience, the last kind of 6 years in this ICU, is that a lot of times, even patient in cardiogenic shock is not necessarily that obvious to everybody. Sometimes it is, but, you know, I've seen enough cases now where there's enough contention that, you know, it takes enough force for multiple physicians to say, you know, the problem here is cardiac before people listen. Of course, echo allows you to help differentiate shock, troubleshoot hemodynamics, look at things like volume status, for example, or even whether pressors and inotropes can be harming a patient, right? Where, say, you have dynamic outflow tract obstruction. Or in troubleshooting respiratory failure, right? Whether it's pulmonary edema, for example, or just simple pneumonia with a normal functioning heart. Of course, there are plenty of caveats. LV dysfunction itself can lead to critical illness for sure, but it can also be a consequence, such as, you know, myocardial dysfunction and sepsis, are simply a coincidence. A patient with myocardial dysfunction who presents with pneumonia, that's a prime example where finding the dysfunctional heart certainly has not really helped you, and it may in fact just confuse you. So to be mindful of that, yes, echo can answer certain questions, but it is certainly no panacea. And the next question that oftentimes gets raised is, you know, if we enhance LV dysfunction, like if we make the LV more functional with inotropes, does it actually do anything? And I would, you know, I think many would agree that there are certain cases where inotropes will actually only make the patient worse, probably increase risk of arrhythmias, for example, reduce their afterload, a number of other, increase their myocardial oxygen demand. So that's one thing to be, again, to be mindful of. Well, there's some basic views here because I'm mindful that not everybody here has the kind of core skill set. So first, some overall arching principles. You know, oftentimes I think the cardio techs, they'll get asked really early in their exam, you know, like, tell me what the ejection fraction is. I want to know. But honestly, it takes time. It takes patience. You got to look at a lot of views, especially the more dysfunction there is, the more challenging it is, especially when it comes to regional motion abnormalities. So you need a lot of patience. And oftentimes, you know, when I'm talking to learners on rotation here, I talk about two orthogonal planes. That's two planes in 90 degrees. So for example, if you have parasternal long, you should have a parasternal short. Okay. If all you have is an apical 4-chamber, well, if you have an apical 2-chamber, that's great because those are, you know, orthogonal planes. If you have a subcostal 4-chamber, well, hopefully you have a subcostal short axis. So, you know, if you only have the bare minimum, hopefully you have at least two of these planes. And frankly, visual assessment of function correlates fairly well with more objective measurements. Now, when you look at the kind of standard of what you see in the echo lab, actually a lot of the cardiologists, like the kind of standard default is just visual assessment. Okay. That the techs often will do what's called a Simpson's method as well. We'll talk about what that really means, where it comes from. Yeah.
Visual assessment has big correlation, but if you have a lot of experience.
Yeah, no, that's
So I think that's
for
a
sure.
caveat, so
It is a caveat for sure. Yeah. Yeah. There's clearly like a reps number, right? Like it's not just that if you look at a few, you can look at all of them. Obviously, it is a skill set, but even then, if you look at one echo, for example, we take 10 cardiologists, they won't always agree. They won't all agree on the same EF. So there is a lot of, there are some challenges with visual assessment. And so we're going to talk more about like a categorical approach than a specific number. That way we buffer against those arguments of 10, 15%, but hopefully you can distinguish between, say, a severely depressed, normal. And of course, LVEF does not equal cardiac output. And this is honestly, if there's one limitation that I can tell you about, it's this one. So if you have a big heart, for example, a big dilated LV, and your ejection fraction is 20%, you may still have a normal cardiac output because your stroke volume may be actually quite large. Okay, if you have a very large chamber. So that's one thing to be very mindful of because it can limit the actual implication of a low EF, for example. Look at the ECG as well. If they're tachycardic, it can make it near impossible to reliably predict function. Myocardial ischemia itself obviously can lead to wall motion changes, and bundle branch blocks are another limitation to visual assessment because the walls aren't all contracting at the same time, and it's honestly very challenging to visually assess an EF without a lot of experience. Because even when you do it by drawing out the volumes, depending on where you measure in systole, can change the ejection fraction. So it's obviously quite challenging. But before you look at the heart, think of what you expect to find. Like, how do the patient present? Do they have risk factors? What are the exam findings? Are they warm in extremities? Are they cold in extremities? Do they have modeling? And what's the most likely diagnosis? If you're a patient who we think has presented with, evidence of community-acquired pneumonia, and you happen to find that the LV function is low, there is a really good chance that those two problems are not necessarily related. Okay, or at least that the LV function is as functional as a consequence of sepsis. Okay, not necessarily the cause of the problem. So this is like the list of acute LV dysfunction in critical care settings. Okay, so this is a huge list. Okay, from MIs to coronary emboli to coronary thrombosis to dissections to stress cardiomyopathy. I guess I want to stress that once you look at the LV, it can be a bit of a Pandora's box. Okay, it can be very challenging to understand what's really going on. And while the expertise is scalable, like you can be someone who assesses a basic and someone who assesses intermediate or advanced, for example, but you need to be aware that you have limitations effectively, especially when you're on the lower end of skill and knowledge. So the first thing is, to actually assess the LV, you need high quality windows. Okay, so if we look at 5 kind of key windows, top left, parasternal long axis, top right, parasternal short, in the middle, subcostal 4-chamber, bottom left, apical 4-chamber, and bottom right, IVC is just a good thing to have as part of your exam. The first thing often you see people have troubles understanding is what's called endocardial resolution. Okay, that's actually making out the endocardium. And you can see on the right clip here, you can see the inner wall of that LV. Okay, and what that allows you to do is really to visually assess myocardial thickening. Okay, I've seen people show me this image and say, oh, look, the EF is depressed. I'm like, well, I mean, yeah, I'm suspicious, but I can't make anything out on the inside. So this is a very unreliable kind of echo exam. So be aware that you do need to have good resolution endocardium to make really any assessment that's even remotely reliable or accurate of the left ventricle. So there's just an example of drawing on the inside of the LV where the endocardium is.
Yeah.
There's a chair there. There's a chair over there too.
Sit behind you and heckle you. What the hell do you think I'm here for?
So the parasternal acquisition, so promarker towards the right shoulder, as you can see there. So that's kind of how it's acquired, and it's just about the 3rd or 4th interspace, left parasternum. There's a typical example. This is a planar technique, so it's just a 2-dimensional shot. there's your aortic root, aortic valve, LV, mitral valve, left atrium, descending thoracic aorta, and of course the heart's in the left chest. So if you see a collection of fluid back here, say for a pleural effusion, that's a left pleural effusion, okay, because you're in the left chest, obviously. So this is a key view to assess even just some basics in function, looking for pericardial and pleural effusions, but it's such a core view. Now with the marker point towards the left shoulder, okay, so the probe's rotated here. So now we're in the orthogonal plane of the parasternal long axis, and that gives us this parasternal short. Okay, so we'd see two different views here, valve level, fish mouth. Okay, we see the LV and it's fully circular, and we see the papillary muscle level as well. Okay, so this allows us to have a good, again, measured assessment of the LV and orthogonal plane. You can see with the LV being circular, it means it's fairly reliable and on axis. Your apical forechamber, marker towards the bed. Okay, and if you feel the apical impulse, that will give you a rough sense of where the apex is, but of course, it doesn't always correlate. Okay, so the best way to acquire this is to have the patient lie in decubitus, but it does shift the apex more laterally. So here we go. So the plane is through this portion of the heart, which gives you a four-chamber view, left ventricle, which generally forms the apex, left atrium, right ventricle, right atrium. And here, this allows us a nice big section of the left ventricle, the septum wall, the anterior portion, the anterolateral portion. IVC just below the xiphisternum with the probe marker towards the head. Okay, I just put this in here for the sake of making sure we get all the relevant data points, and you'll see that the IVC connects third atrium. The subcostal forechamber is basically the probe marker towards the patient's left. Okay, and then you can see that marker is kind of moving up, down towards the sternum. Okay, so there's both some compression and some fanning or tilting, okay, to get under there. And that will give you this view here. This is basically just a different view of like the apical forechamber from a different perspective. Okay, so left atrium, left ventricle, right atrium. So if you're scanning from the outside, you're generally going to encounter liver first through the LV. Okay, so that kind of gives you a sense of anatomically where you are. Okay, so anterior, liver, RV, RA, LV, LA. So this view, some patients may only have really good subcostal views and may have poor parasternal views, even poor apical views. But if you have a really good subcostal view, you can really use it. Okay, especially if you know how to acquire, let's say, a subcostal forechamber and a subcostal short axis. Okay, so that's the next thing here. So almost like an IVC where the probe marker is facing up, rather than focusing on the IVC portion, the probe is going to move basically towards the patient's left side, okay, which basically allows you to have a cross section of the LV. If you draw a line up from this view, okay, you'll notice that it's the same orientation as a parasternal short axis, okay, but it's from under the sternum or under the rib cage. Okay, so being able to generate subcostal forechamber or long axis, short axis is also really helpful, especially in critical care emergency settings where that may be all you have. Okay, so there's a subcostal short axis. Okay, you can see it can be fairly high quality. It really just depends on the patient. So that part is variable. So interpreting function. Okay, so step more here in complexity. Okay, so qualitative versus quantitative. We're going to start here with kind of what's done as per the normal standard. So if you look at quantitative assessment, okay, then you look at diastole, you look at systole, you obviously compare the volumes, right? How much blood is truly ejected from diastole. And Simpson's method, this is what we're doing here, are the kind of biplane method. It means we have two views acquired here, apical forechamber, apical two-chamber, so that's orthogonal planes. Okay, and what's happened is they've drawn lines around the inner endocardium in both the end diastole and end systole, okay, for both views. Now, what this method assumes is that, you know, you see that center line going up to the apex, and there's lines passing horizontally. That assumes that there is a disc, okay, that there at each line represents a disc, because of course the LV is conical, okay, so it's a series of basically concentric circles. So that assumes that the LV is conical and that you know, if you have two different views, orthogonal planes, diastole and systole, that this provides the most reliable way to assess ejection fraction, okay? And it performs fairly well. So Simpson method or method of discs or biplane method, there's a number of ways you can call this. Now, with our current machines or export machines, you can certainly do that, albeit it certainly takes time, and you must have, as I mentioned earlier, really good quality endocardial resolution, so you can really see that heart thicken and can draw the borders in 2 dimensions, okay? So this patient's ejection fraction was 80%, okay, which is obviously quite high. So EF is used as kind of the gold standard to assess function. It can be misleading, of course, as mentioned before. It doesn't always reflect cardiac output. And even quantitative measures can be challenging. So if you have regional wall motion abnormalities, so the LV, for example, doesn't contract at the same time in everywhere across the LV, then the question becomes is like, when do you measure it exactly? Well, you should measure end systole, but of course, the contraction time of the LV is not going to be that as reliable, okay? 3D based measurements are increasingly gold standard, but even 3D measurements have some challenges. 2D measurements by Simpsons, what we just talked about, they can vary as much as 10%. Okay, so you know they're really, you know, when you kind of drill down into how the LV functions, it's actually far more challenging than I think we make it out to be. You know, we call EFs of 30% to 40% or 40 to 45. The truth is there can be a lot of variability. And that's why it kind of makes sense why you just, you know, especially from a point of care standpoint, to have gross categories, because that's just the reality is that it's probably easier to call depressed or severely depressed versus normal. So here's a 3D approach. I just want to put this in here to show you kind of how advanced it can get. Okay, so this really allows for a much more kind of quadrant-based approach to assessing function. But you still need good image quality, and there's lower spatial and temporal resolution, okay? There's more data here, and this requires a much fancier probe, and frankly, inaccessible to a lot of people. Interestingly, though, a lot of current ultrasound probes in the market, like a lot of the portable handhelds, are having machine learning algorithms built into them to do this very thing, okay? To do 3D, 3D modeling of the ventricle to look for ejection fraction. So I suspect while this is only available on more complicated systems at this current time, probably in the next, I'd say 5, it's already available on certain probes on the market. Cosmos, for example, has it. I think Butterfly may be working on it or maybe has it on their probes. But of course, you know, as I kind of point out there, you still need really good image quality. Okay, so that's the important part. So how we evaluate function? We're going to put it down by categories. Hyperdynamic greater than 70%, normal 50 to 70, depressed 30 to 50, severely depressed less than 30%. So here's just an example. If you guys can just take a look and kind of hopefully decide for yourselves what we're looking at here. So 50, 70%, you can see the walls all thicken uniformly. The valve opens really well. Okay, hyperdynamic, there's like very little cavity left. Okay, so the walls thicken a lot. Okay, depressed, there's still some thickening, but it's obviously reduced. The valve opening is a little less. And then severely depressed, what we're seeing here is areas of wall that don't look like they really move at all. Okay, so that would be, for example, what some would call akinetic. Okay, the wall which doesn't really thicken. Okay, there's a bit of lost endocardium here, but you can see on this is the infralateral wall. There's very little movement there. Okay, so being able to classify this is arguably much more important than giving an exact EF. The other benefit of doing a quantitative EF is allows you to track over time. Okay, so that's obviously less of our concern in the point of care world. We're more focused on, again, the kind of point of care setting. So we'll go through a little more of kind of looking at this visual estimation of EF, how I kind of look at it, how many others do as well. So this is the short axis level from the parasternal view. Okay, we're at the level of the mitral valve, and we're looking just at thickening of the mitral valve, or sorry, thickening of the LV. Okay, you notice here that we see the LV all the way around. Okay, the LV cavity should be circular. If it's egg-shaped, then it's going to be off-axis. We look at average changes in wall thickness. So if you're really intense, put M mode across there. and you compared how much is that wall thickened, it should be 25 to 40%. Okay, in terms of wall thickening. And obviously, to address wall thickening, you should really see the endocardium. Another example, so that each segment of the wall should thicken as well. Okay, so you'll notice that at end diastole and systole, it maintains that circular configuration of the LV. So again, if your LV looks almost egg-shaped, there's a high chance that it's off axis. And then another way we can look at this well before our more advanced 2D modes, even 3D modes of ultrasound, M mode was often used as the standard way to assess EF. Okay, now we compare cavity volumes in diastole versus end systole. Okay, but generally M mode is not commonly used that often anymore for assessing ejection fraction. It's more quantitative methods, and frankly, it's more just visual assessment than it is M mode.
You find that looking at that mode as a collective view after multiple views contributes to hinders to making that overall assessment?
No, I mean, I think the question, like, if you have like a few solid views, I'm not sure how much it really helps. Okay, because the M mode again, it's time motion mode, and what that means is you have your image is along the y-axis, and along the x-axis it's not like it's more anatomy. It's just the same plane repeated over time, right? That's the motion part. So the frame rate of M mode is extremely high, like it's much higher than say 2D, like it's around 1400 frames per second versus 2D, which is around 56 frames per second. Okay, so it's very high frame rate. So it does allow, like you can see here, like you are seeing gross amounts of thickening here. Okay, so yes, you could measure it, certainly. But by and large, whether that's going to help you compared to say your visual assessment on multiple views, it's kind of unclear. The other thing that people often will talk about is what's called the EPSS or E-point septal separation. Okay, so basically this right here is the mitral valve. That's the anterior leaflet. Take my word for it. That's the posterior leaflet. But this anterior leaflet in this valve is opening up during diastole. Okay, and with a normal cardiac output of bulk flow, those leaflets, they have good excursion. They come fairly close to the septum. Okay, which means that the LV probably has relatively good cardiac output. It's preserved, and the function is decent. Okay, now people wonder, why is this thing called an E-point septal separation? Of course, there is a reason for it, and I just want to kind of briefly talk about what that is. But usually that anterior leaflet comes within a centimeter of the septum in early diastole. Okay, so that's when the valve's obviously opening and blood is flowing in. So why E-point? Well, in a patient in sinus rhythm, there is two waves. Okay, there's two times when blood flows: when the valve opens, okay, and then you have passive filling of the LV, and when the atrium contracts, okay, which gives you your A wave. Okay, so if they're in sinus rhythm, they'll have an E and an A wave. Okay, of course, if they lose their A wave because of atrial fibrillation, then all they have is their E wave. But the EPSS comes from the E point. Okay, so when this initial large amount of flow happens, how close does that valve come to the septum? Okay, so hence the EPSS. Now, if you think about how this is measured here, then what would be a limitation of using EPSS for assessing function? Anybody can answer.
Mitral stenosis, aortic regurg.
Okay, great. Yeah, so aortic regurgitation for sure can impinge on that valve. So you can have what's called like if you guys, this is a super nerdy take on this, but like an Austin Flint murmur, okay, where the aortic regurg hits the anterior leaflet, kind of closes it, get like a functional mitral stenosis. Super nerdy, but kind of cool from an echo standpoint. The valve is tight, right? If it's the valve stenotic and you have mitral stenosis, then obviously that valve's going to move less. Okay, same with a calcified valve and what have you. Now, if your cardiac flow goes down, okay, because you have an impaired function, then yes, you'll have a reduced excursion here, that mitral valve. But it's a bit more complicated than that. What happens in a heart that undergoes this kind of disfiguration is the actual papillary muscles, they apicalize. Okay, they actually go from, say, here to a little more apex-wise. They really tighten those chordae, and there's less movement. Okay, so the EPSS isn't all just about flow. It's also about configuration of the ventricle itself. So just to be aware that, this technique, while I think good from point of care standpoint, it has a lot of limitations. That's why by itself, I wouldn't rely on it. But certainly looking at, myocardial thickening and then endocardial excursion of coming in, are all really important parts of looking at the ventricle. And here's just an example where, we look at a subcostal view. This patient only had subcostal views, but obviously they were very good, as per typically happens. So subcostal four-chamber, we're looking at that LV. Does the LV walls come in during systole and do they thicken well? Okay, those are two, oftentimes you have to separate those items. Just because the wall moves inwards doesn't mean it's thickening. Okay, and that can happen with certain kinds of dysfunction. So of course we have two orthogonal planes here. Okay, and allows us to kind of put together, what do we think about the function of this ventricle? Think it's depressed, severely depressed, normal, or hyperdynamic? Normal. Yeah, it's fairly normal. Yeah, it contracts fairly uniformly on short axis. On your long axis, there's four-chamber here. You can see it thickens fairly uniformly, decent amount of cavity change. That's a normal ventricle. EF can change rapidly, okay, within minutes to hours for a number of reasons. Okay, things like preload, for example. Obviously, I think people are here familiar with the Frank Starling effect, right? So you increase the preload to a point, you'll have an increase in function. Afterload, obviously, a reduction in afterload can help with function. Inotropes or vasopressors are kind of their adrenergic state can also improve the ventricle for select patients, obviously not all patients, but it can be dynamic, okay? And so it's not unusual for us to see a patient and say like, oh, their function is like really good, like their EF is like 70%, and they're on like 0.3 of epi, and they're on 0.3 of norepi. Then obviously, it's quite possible that the adrenergic state of having those drugs circulating has improved the EF greatly. So just always have that in the back of your mind, that obviously there are some affecting conditions that are going to impact LV function, and that it can change very quickly. Now, headaches, assessing the LV. As I mentioned, a really fast heart rate can be very difficult to assess visually. Okay, and you'll see the cardiologist comment that if you want a good assessment of the LV, maybe we'll come back when the heart rate's a bit better controlled. Okay, for that reason, it's very challenging to assess. Bradycardic patients, to the kind of untrained eye, tend to be underestimated only because they're slower. Okay, which is kind of an interesting just visual trick. Patients with a dilated LV, okay, can also look like they have comparatively smaller changes in volume when their EF is similar or their stroke volume is similar. And then when they have, as I mentioned, significant regional emotion abnormalities can be challenging. If their LV cavity is very small as well, like they have a big, thick LV, it can also be very challenging to assess, because it's simply just that their LV cavity is small, and assessing visually for changes is just more challenging because it's smaller volume. And as I highlighted before, you can have depressed global LV function with normal cardiac output, and you can have an elevated ejection fraction with a low cardiac output, right? The patient who's hemorrhaging, for example, or severely dehydrated can have an EF of 100% and still have a very low stroke volume or cardiac output. And really make sure you learn to exploit other windows. So I have, I myself, and I'm sure Vince, you can say the same thing. I've done a lot of kind of unconventional views of the LV. That way you have a good assessment, because occasionally all you have is one plane, and you want to have more. So we certainly will look for views that are kind of unconventional if our views are more limited. There are some, of course, limitations of assessing the LV, as I mentioned before. So I think I actually covered most of these already, so I don't need to iterate this. But if you have questions, check out the tutorial on Alberto Sono. I go through this in one page, just things to be aware of. Okay, we're going to go through an image interpretation set here. Fine. Okay, case one. What is the gross EF category for this patient? Okay, so the question will be on next slide. There we go. So what is a qualitative category? Look at your phone. You're gonna answer quickly. The faster you answer, the better. So that's correct. 30-50%. Okay. So again, a number of views. Okay, we're looking at here. You know, do we think that the wall motion here, do you think it's fairly uniform, like it's at the same time in terms of contraction and relaxation? Yeah. Yeah, it's right. And so that's one thing to be mindful of as well. It's just like, is it uniform? Okay, because often people get off the tracks when it's not uniform. Okay, bundle branch blocks are a prime example. It's just really hard to assess with bundle branch block. Okay. And then of course you can look at your EPSS, your E point septal separation. It's obviously diminished here, you know, and whether this EF is 25% or 35%, it probably really doesn't really matter. We know that it's in the depressed category, perhaps not severely depressed. Case 2. Okay. What is the gross EF category? Okay. What is the qualitative category of this particular heart? Hyperdynamic, normal, depressed, or severely depressed? Most said severely depressed, some said depressed, and some said normal. Okay. So this obviously, like, the audience here is quite mixed. And I think that emphasizes kind of what Dr. Romanowski mentioned earlier, that in the trained eye, you can perform fairly well. But in people who are learning this skill, there's obviously some subtleties, okay? But these subtleties can be learned. So what are some key things here that you guys picked up that tells you that this is depressed? Yeah. Yeah, it's not moving at all, right? Like it, you know, there's again, so there's that, the endocardial excursion is when the wall moves inwards, okay? But the wall moves inwards slightly, but it's not thickening at all, right? In fact, it might be even a little bit thinned, okay, which makes it more challenging to assess. And then you won't say that this is the anterolateral wall. We actually have kind of lost this area. So we don't really see endocardium there at all. So that certainly is a limitation just to be aware of, okay? As I mentioned before, like seeing the endocardium is really critical to testing LV function. But yeah, this is obviously a very depressed. And now going back to the patient after you see this, the question is, obviously, is this a problem that's making the patient sick? Is this a consequence or is this a coincidence? Okay. And that comes down to everything from your clinical exam, you know, to your clinical findings, to your biochemical, like elevated lactates, for example, troponins, and what have you. What is the gross EF category? Honest recording of this. Okay, so case 4. One clip. LVEF. Dun dun. Hyperdynamic, normal, depressed, or severely depressed?
Sorry.
Yeah, so this is a prime example where EF is really challenging, because obviously I think everybody would see, like, is this global or regional dysfunction? Regional, yeah.
Regional.
Okay, perfect. Yeah. And obviously the problem here is, well, what do we think the diagnosis is here, like, if anything? Obviously. Takotsubo or stress cardiomyopathy. Sorry, it's there. So a stress cardiomyopathy, you know, this is a fairly common occurrence in critical patients. Now, obviously, always be aware that you must rule out coronary disease to make this diagnosis, because patients can have multi-territory findings with certain kinds of left-sided disease. But certainly this looks pretty suspicious. Okay, now the bottom half of the left ventricle, like from mid portion to base, contributes 2/3 of the stroke volume. Okay, the top half contributes about 1/3 of the stroke volume. Okay, so this is really hard, but I would probably put this like in the depressed range. Okay, but like high depressed. Okay, I know that sounds ridiculous, but like it's not normal, but it's just barely. Okay. No, like, so if your depressed category is 30 to 50%, it's probably like in the 40 to 50% range. Yeah. Yeah. Stroke volume is from the bottom, is from the bottom half of the left ventricle.
You mean mid to apex? You're talking about, right? Mid to
Yeah.
apex,
I'm talking about, so in the left ventricle, if you cut it in sections, okay, from the base of the LV near the mitral valve to the half of the LV, that's 2/3 of your stroke volume. Yeah. And then from the top half, from the mid portion to the apex, that's about 1/3. Okay, so the basal portion here, very common in Takatsubos to be like hyperfunctional. Okay, so this obviously is almost hyperdynamic here. Okay, so this portion would have a higher cardiac output, and this portion would have a very, very low cardiac output. So, but again, you know, visual assessment like this would technically need like more of a Simpsons method because it's really just challenging, right? For extra points, if you give this patient a crap ton of epi and norepi, what's the risk that could happen? It's a risk of this patient. Yes, yeah. So LV outflow obstruction. Yeah, because this basal system is already obviously quite active, right? And the basal portion of the LV is quite active. And so that becomes even more functional, okay? And then you create a more kind of a functional, almost stenosis of the outflow tract. It'll suck in that anterior leaflet, okay, and give you dynamic outflow tract obstruction. Okay, so that's always the concern with these patients when they have Takatsubos or stress cardiomyopathy is that you can make them worse with inotropes.
specifically that something because it looks sigmoid already.
It's, yeah, it looks already, you're right, Vince. It already looks fairly disproportionate. So there's something called like a sigmoid septum where the base is thicker than say the mid portion, or a septal knuckle, for example, is another term for it. So if we go back, there's a question about this last case here. Okay. So there's a question about the EF on this one.
Mike, what was your thought?
I was just trying to, because I
Yeah.
I think, wasn't there another slide next to it where there's the parasternal? Yeah, this is what you guys were probably
This
not.
view is normal because the papillary muscles were actually, I didn't think they were quite touching this end.
Yeah, so if you, I mean, certainly like if you use that criteria alone as being antistalk occlusion of papillary muscles, then yeah, it wouldn't be definition for hyperdynamic. But there is a lot of movement here of the left ventricle. That's what led me to think this is more hyperdynamic. Like the LV itself is moving a lot. Okay, that is a little more nuanced though. So if you say normal, that's fine. Like again, we're not aiming for specific percentages here. You're aiming for, is this ventricle normal or abnormal? And for most patients that present who are critically ill, if they're hyperdynamic, that's, you know, are normal. Those two things are fairly close. So just be mindful. These patients can also have one other problem that can occur that can be life-threatening in these patients as well, which happens because of their wall motion abnormalities. Any ideas? Any inklings? Thrombus, exactly. Yeah, yeah. So obviously, this degree of akinesis, the apex, the blood will swirl there. So if you had a better shot of this LV apex, you would see that blood's not moving very much. Okay, and it's probably creating little eddies here in the apex of the left ventricle. And, you know, just because Takotsubo exists in the kind of the octopus trap formation, it can also be reverse Takotsubo and basal ballooning. Okay, again, the endocardial resolution here is limited, but the base is fairly poor. Okay, and the apex is moving more. So there are variants of that theme. There's also mid-ventricular variants. So stress cardiomyopathy is a bit of an oddball in terms of its presentation. Okay, it's often thought to be secondary to catecholamine surge. So just be aware that it's not always that obvious. Okay, so clinical integration. So, you know, this is where kind of the rubber hits the road. Really, you know, I got to consider whether any clear evidence of exam of biochemically LV dysfunction. This is by far, I think, the hardest part, okay, because it really requires you to think, what was your pretest? What was your post-test probability, right? Did you really think that the LV dysfunction was the problem? Or do you have any suspicions of risk factors or, you know, ECG evidence? But also look for other findings for, you know, for example, pulmonary congestion. B lines and pleural effusions, for example, would support that perhaps this is left-sided failure. And there's also suggestions looking for venous congestion, which gets more advanced and a little more contentious. But in any event, integrating it is probably the most important part and really requires you to put on your clinician hat. So in summary, this is a common occurrence. Okay, again, can be the cause, can be the consequence, or can be coincident. Okay, and it requires multiple views in patients. The kind of quantitative method is the most common method. You know, increasingly they're doing more 3D echo, but that's also more expensive and requires more equipment. And from a point of care or critical care standpoint, or whether emergency department or ICU, having a visual assessment with 2 planes and good resolution offers a lot. Okay, be aware of this whole idea about LVEF and cardiac output, and be aware of the many visual confounders like tachycardia, bradycardia, for example, and also, as we talked about, the regional wall motion abnormalities. So that's all I had for today. Thank you, everybody, for listening. That's all I had.